Uh, Next, we have Dr. A.B. Jacob. He will tell us about intricacies of cataract surgery in a filtering eye, in a post-strab eye.
Thank you, Thomas George. Ronnie said that it is a pleasure to be here. For me, this is weather back home, -1 degree centigrade. So I'm really happy to be here. Great. So we know that 50% of cataracts, trabeculectomies will tend to produce cataracts in phakic patients if you follow them up over a period of 5 years. The mechanism of cataract formation is not very well understood, but we also know that if you have problems like a flat anterior chamber following cataract surgery, your chance is almost double, more than double, of developing cataracts. Cataract surgery also increases the chances of blood failure. Various theories are promoted, but then nobody really again knows the answer to this question. So cataract surgery is done following trabeculectomy in a few situations. The standard one is a routine cataract extraction when we do an elective surgery a few years down the line. But then there can be also the desperate cataract surgery in things like aqueous misdirection or a flat anterior chamber where you have to create space within the anterior chamber. But I'm not going to deal with that because that's a totally different ball game. You can also find in certain situations that your lens can get intumescent and sometimes block the ostium, and then you might need to open up the angle, and therefore that'll be a sort of a phacomorphic sort of situation. The aim, of course, is to improve vision, but then it also improves your visibility into the to look at the disc and assess the progress of glaucoma, because ultimately we are dealing with a glaucoma here. You have to minimize the loss of intraocular pressure control by using anti-scarring agents if you need to, and minimize the risk of scarring. Again, people have talked about all these things. We tend to try and keep it less complicated and try not to do any fancy stuff. If not absolutely required at the time, just try and do a decent cataract operation and get the hell out of there. Following surgery, of course, you have to watch them very carefully and treat it appropriately. Risk of failure is increased in young patients. Patients who already have high IOP, quite often they'll be on meds. Unlike the standard trabeculectomy patient who has been off medications for quite some time. And then, of course, early intraocular pressure spikes is a risk, manipulation within the eye, and then, of course, the dreaded posterior capsular rupture and vitrectomy. So blebs can be associated with any of these operations that are here on this list. And I'm therefore not deliberately including all the microsurgeries that we do these days. It's also important to make an assessment of the bleb to make sure whether there's a nicely functioning bleb or whether it's a so-so bleb or is a failing bleb. Then, of course, your strategy changes a little bit. Of course, who is doing the operation? See, I work in a teaching hospital, so there are fellows who want to operate on these post-trabeculectomy eyes, so you need to decide who is doing it. And then, of course, I also operate in 3 different theaters, so you need to find good theaters, the theater with the best team to do these things. Very important that you start planning early, and you need to start looking for all those risk factors that could be lying buried in this patient who has had a trabeculectomy 10 years ago. So finding the operative notes is very important. Looking for any potential weaknesses on the lens zonules is very important. Planning, mitomycin, FIFU, all those things, and like I did mention earlier on, opening up angles sometimes once in a while. Again, you want your patient to earn the surgery. This is an operation that could potentially lead to the bleb to fail. So you want this patient to be symptomatic at least. Having said that, you don't wait till it becomes a really difficult operation. Because like I did say, the one thing that you have to do is to get a safe operation without a vitrectomy. Anything else, a glaucoma surgeon will be able to manage. Okay. So here is someone who has had a cataract operation some time ago. This was a very avascular sort of bleb. We did give her some mitomycin, and we did break the. I'm sorry, I don't have a point here, but we did break um, the edge where the ring of steel was. And despite that remaining sort of avascular and horrible looking, um, that bleb is still functional and the pressure is quite reasonable. And I thought I think I pressed the wrong button. Okay, and that's an OCT of that same bleb, and you can see that there's a ring of steel at the back, but there are areas through which that is leaking adequate aqueous to keep that intraocular pressure under control. This is the fellow eye of the same patient. This needs to go for cataract surgery, and you can see this is the sort of cataracts that we do back in the UK. Unlike the ones that you guys were doing trabs on, they would have had their cataracts a long time earlier. And this is a lovely bleb, and you have to have a strategy to operate on someone like this. Here again, I'd probably use a mitomycin in the area where there's no bleb, but I'll definitely give some intraoperative mitomycin and just make you sure that you have a clean surgery. This is again another one that requires surgery. So as you can see here, I use a strategy. I use no mitomycin in someone like this because I want that bleb to look a little more vascular if possible. I want that bleb to fail a little bit. That pressure is very low. It's running at around 4 or 5. If it goes up to 7 or 8 or 9 or 10, I don't have a problem. I don't lose any sleep over that. So again, like I did say, you have to be sure of the theater where you're operating on these patients. You need to know you need to have planned your strategy, whoever is doing the operation, and you need to be prepared for whatever is coming. Of course, you have to we have to order out the mitomycin. You can't draw mitomycin in the theater. So the mitomycin has to come from the pharmacy, so it has to be there. Otherwise, you can't do the operation. You have to protect the bleb, especially if you have dodgy blebs of the sort that I showed you, because they can get damaged during the procedure, and you don't want to do that. Other interesting thing is astigmatism management, and it is something that I'm getting interested in these days, because you get these funny blebs and you wonder whether you should correct it. I tend not to correct the whole of it. I tend to correct a little bit of it, and patients seem to be happy. It might just be because the pressure did go up a little bit, and because especially if someone has a lower IOP, any astigmatism tends to get exaggerated. So just need to be aware of that too. And I've deliberately put phaco versus 6 versus ECI here, because again, there are people here, I'm sure, who operate in different situations. You don't have to be embarrassed to do an ECI or a 6, because again, like I did say in the beginning, the most important thing is not to do a vitrectomy. Anything else, most glaucoma surgeons will be able to manage. I have the luxury of using intracameral dexamethasone. So again, I tend to load the anterior chamber fully with dexamethasone these days, and a little bit of cefuroxime. That's antibiotic of choice in the UK, because that helps to sort of kick off the process without you having to give a subconjunctival injection and disturbing the conjunctiva separately again. Post-operatively, of course, you have to be very intensive with the steroids. You can use ketorolac or nepafenac as required. Quite often, we tend to do it for these patients who do have any sort of diabetes or any macular problem, but not on a regular basis. I think I'm almost finished. Yeah, thank you very much. Any questions? We'll take it. Fabulous. If anyone